Hello everyone, today we'll be discussing acute coronary syndrome. This presentation will provide an in-depth overview of acute coronary syndrome, focusing on advanced management strategies. In this video, we're going to cover the pathophysiology, diagnosis, and management, as well as long-term care protocols of acute coronary syndrome. Pathophysiology and classification of acute coronary syndrome. Underlying mechanisms of acute coronary syndrome. ACS primarily results from atherosclerotic plaque rupture that leads to thrombus formation and myocardial ischemia. Inflammation, endothelial dysfunction, and platelet aggregation play a key role in the pathogenesis. Clinical spectrum of acute coronary syndrome, we have got ST elevation myocardial infarction, non-ST elevation myocardial infarction, as well as unstable angina. This is based on ECG findings as well as cardiac biomarker elevations. Each entity varies in severity and urgency. That leads to guidance on specific therapeutic approaches. So when we look at ST elevation MI, you're going to notice that there will be ST elevation on ECG, okay? And in such cases, patients require urgent reperfusion therapy to restore blood flow. Then we've got non-ST elevation MI that prevents with elevated cardiac biomarkers without ST elevation. This also needs early medical management. Then we've got unstable angina overview. In this case, patient will present with chest pain. However, there will be no biomarker changes or ECG changes. Such patients require close monitoring as well as treatment. So when we look at acute coronary syndrome, we look at non-ST elevation MI and we look at the ST elevation MI. Okay, so this is a blood vessel. When you look at this blood vessel, you can see that there is a complete occlusive thrombus here, due to which blood flow is interrupted. Then in non-ST elevation MI, there is a partially occlusive thrombus. Okay, so this is what you'll see on angiographic findings. When we talk about electrocardiographic changes, in non-ST elevation MI, you may notice ST depression as you can see here, or you may notice T-wave inversion. Okay, so basically what we're saying is on ECG there will be not specific or no electrocardiographic changes. Okay, then when we talk about biomarker changes, which is cardiac enzymes, in unstable angina, cardiac enzymes are going to be negative. In non-ST elevation MI, cardiac enzymes will be positive. Then when we talk about ST elevation MI, when we look at the ECG, you'll notice there will be ST elevation as you can see here. So that is, so what do we mean when we say ST elevation? So it has to be in more than 2 contiguous leads on standard 12-lead ECG, or ST elevation on posterior lead ECG. Then one thing we need to know about cardiac enzymes is might be negative if it's immediate, if the patient presents immediately, okay, after symptom onset, because it takes a few minutes to hours for the cardiac enzymes to become positive. Then we look at some ECGs, okay, so that is myocardial infarction, and then we have got some ST elevation MI mimics as well as ST-MI elevation equivalents, okay. So this is just an ECG showing ST depression, as you can see here. Then this one is showing T-wave inversion. Then this one is showing ST elevation, okay. Then these are some STEMI mimics, okay, that will look like ST elevation, or they will have ST elevation, but they're not myocardial infarctions, okay. Then we have got some ST elevation MI equivalents. So that is the winter waves, okay, STT elevation, isolated posterior STEMI, Wellen sign, new right bundle branch block. Then we've got this Carbosa criteria. Risk stratification and prognostic indicators. So we've got some risk assessment models such as the TIMI and GRACE scores. They predict patient outcomes and guide treatment intensity effectively. Okay, in the next slide, we'll discuss on the TIMI and the GRACE scores. Then clinical presentation, patient symptoms and signs are crucial prognostic indicators in clinical risk stratification. ECG and biomarkers, ECG changes and biomarker levels provide essential information for prognosis and management. Then comorbidities impact. Existing comorbidities significantly influence patient risk and treatment decisions. And now this is the TIMI score and this is the GRACE score. So in TIMI score, we've got a few factors that need to be kept in mind. Age above 65. If the answer is yes, it's 1 point. If it's not, 0 points. Then greater than or equal to 3 risk factors for acute coronary syndrome, which is hypertension, hyperlipidemia, smoking, diabetes, or a positive family history. Then use of aspirin in the last 7 days. Prior history of coronary stenosis of more than 50%. More than or equal to 2 angina events in 24 hours or persisting discomfort. Then ST segment deviation of greater than or equal to 0.05 on initial ECG. Elevated cardiac biomarkers. So total score, if it's low risk, 0 to 2, okay? If it gets to 3 to 4, that is intermediate risk. And if it's 5 to 7, that is high risk, okay? Then the same way we've also got the GRACE score, which keeps in mind age, heart rate, systolic blood pressure, creatinine, and the Philip class, okay? Then low risk is if the value is between 1 to 88, intermediate risk if it's 89 to 118, and high risk if it's above or greater than or equal to 119. Initial assessment and diagnostic strategies. So one thing we need to remember, what we've already discussed, is the first step of evaluation is an ECG, which helps to differentiate between STEMI and non-STEMI as well as unstable angina. Okay? Then cardiac enzymes, especially troponin, CKMB, is important in assessing the non-STEMI versus myocardial ischemia without tissue destruction. Chest X-ray often may be useful in diagnosing causes other than MI that present with chest pain such as pneumonia or pneumothorax. Clinical evaluation and risk assessment tools. So comprehensive patient history is essential for early detection of acute coronary syndrome, symptoms, and risk factors. Physical examination importance. This helps identify clinical signs that are critical in diagnosing acute coronary syndrome. Then use of risk assessment tools. Validated risk assessment tools guide stratification and help in planning appropriate treatment strategies. For electrocardiography and cardiac biomarkers, ECG is the primary tool to detect ischemia or infarction patterns in cardiac patients accurately. Role of cardiac biomarkers. Cardiac biomarkers like troponin confirm myocardial injury and help differentiate acute coronary syndrome subtypes. Imaging techniques and additional diagnostics. Echocardiography can evaluate myocardial function and help in detecting structural heart abnormalities in acute coronary syndrome patients. And coronary angiography, this visualizes coronary arteries to identify blockages and guide coronary interventions. Additional imaging modalities, other imaging techniques complement diagnostics to detect complications and assist interventional planning. Pharmacological management in the acute setting. Pharmacotherapy in acute coronary syndrome aims to prevent plaque progression, reduce myocardial oxygen demand, and manage complications. In this section, we'll review the key drug classes as well as their clinical application. Immediate management of acute coronary syndrome. The primary goals of therapy for patients with acute coronary syndrome are to 1. Reduce the amount of myocardial necrosis, 2. To prevent major adverse cardiac events, such as death, non-fatal MI, and need for urgent revascularization, as well as treat acute life-threatening complications of acute coronary syndrome. Then the treatment or management. So the basis is analgesia, antiplatelets, aspirin, nitrates, and oxygen if needed. Okay. So the initial treatment for acute coronary syndrome patients includes aspirin 300 milligrams and heparin bolus, as well as IV heparin infusion if there are no contraindications. Antiplatelet therapy with ticagrelor or clopidogrel is also recommended. However, what we need to know is that ticagrelor is not given to the patients receiving thrombolysis. Then supportive measures like pain control with morphine, fentanyl, as well as oxygen in case of hypoxia are provided as required. The nitroglycerin sublingual infusion can be used for pain relief as well. This is just a brief explanation on the initial management, okay? Now we'll discuss all of this in detail in the coming slides. Let's have anticoagulant therapy. Dual antiplatelet therapy combining aspirin and P2Y12 inhibitors effectively prevents platelet aggregation and reduces clot formation risk. Use of anticoagulants such as heparin inhibit clotting factors and complement antiplatelet therapy in ACS treatment. Therapy goals. The combined therapy aims to reduce thrombus formation and improve clinical outcomes in acute coronary syndrome. Then the role of beta blockers, lipids, and statins. Beta blockers role. Beta blockers decrease myocardial oxygen demand, helping to protect the heart during acute coronary syndrome. Nitrates help relieve ischemic chest pain by dilating blood vessels and improving blood flow to the heart. Statins benefits. Statins stabilize arterial plaques and lower lipid levels, improving prognosis in acute coronary syndrome. Analgesic treatment options for cardiac chest pain. We can use nitroglycerin sublingual 0.3 to 0.4 milligrams every 5 minutes as needed, up to a total of 3 doses. However, what we need to take note is the patient must be hemodynamically stable with a systolic blood pressure of more than 90 millimeters mercury. We can use nitroglycerin IV as well, starting at 10 micrograms per minute and titrate to pain relief and hemodynamic tolerability. So this is considered for persistent anginal pain after oral nitrate therapy, or if acute coronary syndrome is accompanied by hypertension or pulmonary edema. However, what we need to know is we need to avoid the use in suspected right ventricular infarction, systolic blood pressure of below 90, or if there is a change in systolic BP of more than 30 millimeters below baseline. Then morphine IV can also be used for pain relief, 2 to 4 milligrams, and may be repeated if needed every 5 to 10 minutes, 5 to 15 minutes. And you can consider dosing of up to 10 milligrams. And this is used for pain relief that is resistant to other maximally tolerated anti-ischemic medications. What we need to know is that it may delay the effect of oral P2Y12 therapy. Then we can also use fentanyl IV, 25 to 50 micrograms, and may repeat if needed. Doses up to 100 micrograms may be considered. Then dosing considerations for oral antiplatelet therapy in patients with acute coronary syndrome. Aspirin in non-ST elevation or ST elevation MI. So loading dose of 162 to 325 milligrams orally. Aspirin non-enteric coated should be chewed when possible. That way there is a faster onset of antiplatelet action. Then loading dose should be administered for patients that are already on aspirin therapy. Maintenance dose is 75 to 100 milligrams orally once daily. Then clopidogrel should be given in non-ST elevation or ST elevation MI without fibrinolytic. So the loading dose is 300 or 600 milligrams orally with a maintenance dose of 75 milligrams once daily. Then STEMI with fibrinolytic loading dose is 300 milligrams orally if age is below 75 years. Then initial dose 75 milligrams orally if age is above 75 years. Then prasugrel can be used in non-ST elevation MI as well as ST elevation MI without fibrinolytic and undergoing PCI. Then ticagrelor, non-ST elevation MI or ST elevation MI without fibrinolytic. Loading dose is 180 milligrams orally with a maintenance dose of 90 milligrams orally twice a day. Acute coronary syndrome, so initial selection of oral P2Y12 inhibitor. If they're undergoing PCI, aspirin plus ticagrelor or prasugrel. Clopidogrel when ticagrelor or prasugrel are not available. Then if they're going a CABG, aspirin plus ticagrelor or clopidogrel. Then continue aspirin during the CABG and start P2Y12 inhibitor when safe postoperatively. If there is no planned invasive evaluation, aspirin plus ticagrelor can be given. And fibrinolytic in ST elevation MI, you give aspirin plus clopidogrel. Then parenteral anticoagulation. In patients with non-ST elevation ACS, IV unfractionated heparin is useful to reduce ischemic events. Then in patients with non-ST elevation ACS in whom an early invasive approach is not anticipated, either enoxaparin or fondaparinux are recommended, alternatives to unfractionated heparin to reduce ischemic events. Lipid management. In patients with acute coronary syndrome, high-intensity statin therapy is recommended to reduce major adverse cardiac events. Okay, so when we talk about high-intensity statin therapy, we are referring to atorvastatin or rosuvastatin. The doses are 40 to 80 milligrams once a day, or rosuvastatin 20 to 40 milligrams once a day. Beta blocker therapy. In patients with ACS without contraindications, early, which is less than 24 hours initiation of oral beta blocker therapy is recommended to reduce the risk of reinfarction and ventricular arrhythmias. Renin-angiotensin-aldosterone system inhibitor in high-risk patients with ACS with ejection fraction of below 40%, hypertension, DM or ST elevation MI with anterior location, an oral ACE inhibitor or angiotensin receptor block is indicated to reduce all-cause death and major adverse cardiac events. So this is just a basic guideline on management of patients with symptoms suggestive of ACS. So when patients start experiencing chest pain or basically symptoms that may be pointing towards acute coronary syndrome, so they can be two ways, okay? Either patients call 911, which is preferred, or patient takes on transportation. If patient takes on transportation and they arrive at a non-PCI center, your to ECG time should be less than 10 minutes, and the diagnosis for ST elevation MI to be made immediately based on the ECG. However, if they arrive at a PCI center, door to ECG time should be less than 10 minutes, diagnose ST elevation MI and activate cath lab. Then if patient calls 911, which is the preferred route, EMS will obtain the pre-hospital ECG within 10 minutes and suspect ST elevation MI. Based on that, they can determine the destination of the hospital. When they can transport to a PCI center, so they can request for activation of cath lab. Then if they get to a non-PCI center, we go back to this one here. FMC, so either you get to the non-PCI center through the emergency services or through on transportation. There can be two alternatives from there, okay? Then PCI center commits to reperfusion strategy, okay? So now from there, they can be two ways. They can be fibrinolysis or primary PCI. If primary PCI is feasible within 120 minutes or lysis is contraindicated, activate cath lab for PPCI and urgent transfer to PCI center, and preferably bypass emergency direct to cath lab if it's feasible. Then they get to the cath lab. Then if you go for fibrinolysis therapy, that is if primary PCI is not feasible within 120 minutes, or if goal door to lysis time is less than or equal to 30 minutes, you assess patient for reperfusion after lysis. Arrange for immediate transfer to PCI center if lysis failed or patient unstable. Arrange for urgent angiography for rescue PCI. If lysis is successful and patient is stable, arrange for early angiography. So recommend reperfusion at PCI capable hospitals. Recommendation for primary PCI in ST elevation MI. When in patients with ST elevation MI that present less than 12 hours after symptom onset, primary PCI should be performed with a goal of FMC to device activation of less than 90 minutes or less than 120 minutes in patients requiring hospital transfer to improve survival. Then coronary angiography and PCI after fibrinolytic therapy. One, in patients with ST elevation MI, transfer to a PCI capable center immediately after fibrinolytic therapy is recommended. In patients with ST elevation MI with suspected failed reperfusion after fibrinolytic therapy, immediate angiography with rescue PCI is recommended to reduce the risk of death or recurrent MI. Then in patients with ST elevation MI treated with fibrinolytic therapy, early angiography between 2 and 24 hours with the intent to perform PCI is recommended to reduce the risk of death or MI. Now when we talk about fibrinolysis, what are we referring to? So we've got fibrinolytic agents, these tenecteplase, reteplase, and alteplase, okay? As well as streptokinase. In the US, it's no longer being used, but in other countries, it's still commonly being used for fibrinolysis. Choice and timing of management strategy in non-ST elevation SCS. So if the patient is unstable or very high-risk patient, any of cardiogenic shock, signs or symptoms of heart failure, refractory angina, hemodynamic or electrical instability, immediate invasive strategies recommended. Then high risk and ST elevation, any of if the Grace risk score is above 140, steeply rising troponin values on serial tests, despite optimized medical diagnosis, ongoing dynamic ST segment changes. The routine invasive coronary angiography should be done in less than 24 hours. This goes under class 2A. Then intermediate risk and FT elevation MI, any of the grade risk score being between 109 to 140, absence of ongoing ischemic symptoms, stable or downtrading troponin values. The routine invasive, which is class 1, coronary angiography is recommended before hospital discharge, which is less than 72 hours. Then lower risk non-ST elevation MI, any of Grace risk score below 109, TIMI risk score of less than 2, absence of ongoing ischemic symptoms, troponin is less than the 99th percentile, and no dynamic ST changes. The routine invasive or selective invasive. Non-invasive risk stratification during hospitalization or recurrent symptom, or coronary angiography before hospital discharge. Then discharge or long-term management and secondary prevention. Dual antiplatelet therapy strategies in the first 12 months post-discharge. In patients with ACS who are not at high bleeding risk, DAPT with aspirin and an oral P2Y12 inhibitor should be administered for at least 1 year to reduce major adverse cardiac events. In patients with ACS who have tolerated DAPT with ticagrelor, transition to ticagrelor monotherapy greater than or equal to 1 month post-PCI is useful to reduce bleeding risk. In patients at high risk of GI bleeding, a PPI is recommended in combination with DAPT, oral anticoagulants, or both to reduce risk of bleeding. Management of complications and adjunctive therapies. Addressing complications such as heart failure, arrhythmias, and cardiogenic shock is critical. Adjunctive therapies include ACE inhibitors and analgesics to enhance patient care. So, reperfusion strategies and interventional approaches. Timely reperfusion is vital to salvage myocardium. Indications for primary PCI. Primary PCI is the preferred treatment for ST elevation MI patients when performed within recommended timeframes for better clinical outcomes. Indication factors for PCI dependent on clinical presentation, available facility capabilities, and specific patient health factors. Then the role of fibrinolytic therapy. Fibrinolysis is an alternative when PCI is unavailable, within guideline recommended time windows aiming to dissolve clots and restore coronary blood flow properly. Timing and selection of invasive management. Risk stratification important. Assessing patient risk helps determine the need for early invasive management or conservative treatment. Clinical stability consideration. Stable patients may be managed conservatively, whereas unstable patients often require prompt invasive intervention. Then resource availability factor. Availability of medical resources influences timing and selection of invasive procedures for optimal outcome. Secondary prevention, rehabilitation, and long-term follow-up. We have both lifestyle modification and cardiac rehabilitation. Lifestyle changes include diet, exercise, smoking cessation, and stress management, supported by cardiac rehab programs, significantly reduce recurrent cardiovascular events. Long-term pharmacotherapy and risk factor management. Chronic use of antiplatelets, statins, beta blockers, and ACE inhibitors, alongside control of hypertension, diabetes, and lipids, is essential in reducing long-term morbidity and mortality. Regular clinical evaluations, diagnostic testing, and patient education empower adherence and early detection of complications, ensuring optimal long-term care in ACS survivors. Conclusion: effective management of acute coronary syndrome requires a multidisciplinary approach, integrating timely diagnosis, evidence-based pharmacological and interventional therapies, and comprehensive secondary prevention to improve patient outcomes. That's all about acute coronary syndrome. If you like the video, please like, subscribe, and comment. Thank you.